Let me now move to the non-transplant candidate. Are these patients, is possible in this patient to have the dream of curing some of them? If the patients are a standard risk, probably there are good chances to think about long-term remission at least. Again, in the elderly patients, newly diagnosed, we have nowadays two standards. VMP, for those that like alkylators, or RD, even VRD, for those that don't want to use alkylators. And again, both standards has been recently compared with the same, but adding a monoclonal antibody, again, daratumumab in this case. And in both studies, there is a clear benefit in favor of the addition of a monoclonal antibody. In terms of progression-free survival, daratumumab plus BMP, 36 months versus 19 months in the BMP in the control arm. This benefit, again, was not so high in the high risk. This benefit in PFS was mainly based on the deeper response rate achieved by adding a monoclonal antibody. The CR rate is almost double, 25 versus 45%. MRD, 27 versus 7%. Dara VMP, I would say that improved the outcome in the high risk, but does not overcome the poor prognosis of the high risk. Well, what about the other comparison? The RD, lenalidomide dexamethasone versus lenalidomide dexamethasone with daratumumab. In this study, the median PFS has not been achieved in the experimental arm. It's 31.9 months, almost 32 months. In the control arm, very good lenalidomide dex performance. But if you look to the 30 months, PFS is 71% in the experimental arm versus 56% in the control arm. And again, this was mainly based on the depth of response. CR rate 48-25, almost the same. MRD almost the same, 24 versus 7%. Therefore, I think we now have new standards for the elderly patients as well. But our problem is the high risk. In the high risk, none of the data that I has already discussed with you indicate that we have reached a good pathway. We need to improve. And the only evidence that we have is that in a high-risk patient, in which the plasma cell, the clonal plasma cell, have a nasty gene, such as P53, or P53 plus 1q or 414, double hit, if you don't eradicate these cells, even if these cells are maintained at very low levels, 10 to the 4, very low levels, these cells will regrow again and will be responsible for very resistant disease, in many cases with extramedullary disease. Therefore, the only guide that we have in this patient is to get rid of these residual cells, and MRD is the only marker that has shown benefit in the high risk. Let me explain myself. The patients that achieve even revised ISS3, that achieve an MRD negative status, do as well as a standard risk with residual disease and close to a standard risk without residual disease. In other words, MRD negativity should be our goal in the high risk. And for this reason, if I treat a patient with high risk with Dara VRD, or we are going to have other monoclonal antibodies, isatuximab VRD, or ISA KRD, whatever, the quadruplet, plus an autologous transplant, or without transplant, and the patient is high risk, and still there are residual cells, the consolidation, for me, should be totally different. And we need to move the new tools. And what are those new tools? Immunotherapy. We have the monoclonal antibodies The conjugated monoclonal antibodies, belantamab, that has shown 40%, 30% responses in heavily pretreated refractory patients. But even more appealing is the bispecific antibodies. And in the future, we are going to have trispecific antibodies. And we have already data with CC93269, or more recently is going to be presented at IGA, teclistamab. Both of them, these bispecific T-cell engagers targeting the T-cell, the CD3, and the clonal cell, the plasma cell, shows 70, 80% responses at the optimal dose with impressive CR, around 40% CRs. Therefore, I think this is the way to early rescue intervention in those patients with high risk. The other alternative, and we have already clinical trials, is the CAR T cells, just one shot in order to eradicate this cell. We know the value of CAR Ts. Probably some people said, okay, but it's not so valuable because the median PFS is around 1 year. Yes, but you are talking about end-stage disease. If you move the CAR Ts to early-stage disease, probably the panorama can be very, very different. And CAR Ts have shown the capacity to induce response in the vast majority of these heavily pretreated without options, and most of these CRs were MRD negative. What we need is to maintain this situation, and you can maintain either by giving something else after the CAR T or by moving the CAR T earlier. And for the high risk, I think this is one of the most promising ways. Therefore, my conclusion is that although we have made great progress in recent years, I think we are not yet in a situation to call myeloma a curable disease. But the panorama is good. We are in the way, and we need to work together. And we need to have dreams. If you are conservative, you are never going to a good place. You need to be really, doctors and patients should have in mind that we can do better. We cannot be happy with what we have got, which we have, okay, let me say, we can be happy, but we also be ambitious. And this ambition should be for having many of our patients going back to work, going back to enjoy their life in the families without treatment. And this will be, because this will be cured. And we have probably done quite a lot in the standard risk. We need to improve in the high risk. And I want to close by thanking all of you for your attention.